Okay, well, these are my tricks, you know, and they are great experts, and they will share with us their own tricks. And the first thing is that when you have anterior and posterior PVR, where to begin? In many books and papers and, you know, many things, you will hear about to begin with the posterior PVR first. And I do the contrary. I manage first the anterior PVR. Why? Because when you have anterior PVR and you begin to, you do your vitrectomy and then you inject perfluorocarbon liquid and then you remove your instruments from the inside and the anterior retina is stretched, then it's very easy when the fluid strikes the perfluorocarbon liquid to produce these bubbles, then you have breaks in the periphery, the retina is stretched, the door is open, and it's very easy to have perfluorocarbon liquid under the retina. Then never perform, in my opinion, never perform retinectomies in the beginning, never. Try to remove the membranes, because if you cut the retina in the beginning, you will digest much more retina than expected. And then you will have this gap between the anterior retina and the posterior retina. And the important thing is that at the end you can end it with these Vietnamese rolls. Then be careful, because in these rolls the membranes are inside the rolls, and then you have to unroll these rolls, and then you look for the membranes, and then you remove them. This is very difficult to perform. You can have, you know, this picture, it was wonderful, but you know, at the end the visual acuity in these patients can be very low. Then how to remove these anterior membranes is not so difficult. You enter in the eye, you grab a forceps and a scissors, and you try to find the anterior border of the vitreous base with the membranes. You grab the membranes, and you go up, and then you arrive to the posterior vitreous base, and then, to the posterior border of the vitreous base, and then you cut it, and you cut it, and you cut it, and you cut it, and you cut it, because the membranes are in the inferior part of the retina, as you can see here. This is, you know, takes, you know, 8 to 10 minutes to do it. If you pull these membranes with one forceps or two forceps, you will break the retina. And at the end you will say, oh, this is boring. Then I'm going to cut the retina, and you will digest much more retina than expected. Of course, not all the cases are very easy. You know, you have this case, for example, that is not so easy. I always perform lancectomy in these cases. And then in these patients, you have to unroll these rolls of the anterior PVR, try to find to relax the anterior part of the retina, as you can see here. You can look at this. Oh, I'm sorry for that. Okay, I'm here. Here?
Yes.
I'm sorry for that. Is this one? Okay. Yeah, I'm here, yeah. Then this is the trick, just to go with the membranes. What about posterior PVR? Okay, what about posterior PVR? In posterior PVR, it's very, you know, let's say easy to perform. The thing I do is always stain the membranes. I always stain. You can see the membranes without staining, but you know, staining will give you more membranes to remove it. Then more secure, more safe to remove these membranes. Look at this. We go, in this case, from posterior to anterior, because there is no anterior PVR. Let me show why I stain under air, because under fluid, you know, when you have this retina totally detached, you have the folds, then it's very difficult for the dye to get in contact with the membranes. Then I put air in the eye, and then I open the folds, and then I stain over the membranes. I'm going to show you. Look at this. This is a not so difficult case. Then the first thing we do is, then under air, I have a cannula, and then I inject some bubbles of dye over the suspected membranes. Then look at the membranes. They're stained in blue, and there is very easy with one forceps to try to peel all of these membranes. And always try, in my opinion, always try to remove the internal limiting membrane, because, you know, if I think 30 years ago, when I was, you know, treating these cases to now, I have now less and less epiretinal membranes after the PVR cases. Okay, I always work on the perfluorocarbon liquids. Many surgeons say, don't work on the perfluorocarbon liquids. You have a high risk to have perfluorocarbon liquids under the retina. Believe me, this is not true. If you have a big hole in the macular area, of course you can have a bubble. But in the cases, normal PVR, you have the membranes in the mid-peripheral posterior part and the posterior part, believe me, on the perfluorocarbon liquid is much easier to perform it. Look at this. This is a video I made, upper left. I made in '89, I think, in New York in a course of Stanley Chang. And this is my hand many years ago, and it was how acts the perfluorocarbon liquid at pushing the retina down, and you are playing between the elasticity of the retina and the rigidity of the membranes you can see here. Okay, in summary, the things I do, look at this. This is a PVR case, mostly posterior PVR case. And then I do air first. I try to absorb, you remove part of the subretinal fluid, and I inject over the membranes, you know, in the dye goes down to the macro area. And you will stain the anterior membranes and posterior membranes, and you remove the air, and then you put perfluorocarbon liquid that you will see now. Let me go fast too. And this is the aspect after the case. This, you know, this is very rare to obtain 0.7 vision in a PVR case, I know. I show you the most important, one of the best. Look at this. This is only 1 minute. This is a primary PVR. In primary PVR, remember, first put a buccal in. I am the guys, in the group of guys that we perform buccal surgery. Then do buccal surgery because this patient won't need any retinectomy. Then, let me try to begin the video. Okay, look at this. This is a primary PVR. Patient has not been previously operated. Then, in summary, remove all the vitreous, as you can see here. Central and peripheral vitreous. Then fluid exchange. You stretch the retina, and you won't attach the retina because there are folds there and membranes. Then stain the membranes. And you will see now when you remove this fluid and the dye and everything, and you put perfluorocarbon liquid, look at this. It helps you to discover tiny holes around the vessels. Then you remove all of this dye under the retina and over the retina, as you can see here. Then again, go to perfluorocarbon liquid, remove all the dye, and you will see the membranes. And it's very easy to peel these membranes out because, you know, it's so easy to see this blue color over the retina. It will help you to discover all the membranes and to remove them. Remember, remove the internal limiting membrane. This is my advice. And at the end, laser around the bags, and this is the aspect after the treatment. Never retinectomies in the beginning, and try to be as much as anterior as possible. If you have posterior subretinal PVR, there are different ways to do it. One way is do like this, make a hole in the periphery and put a forceps, as you can see here. I try to move this, but okay. You insert a forceps, and then you can grab this membrane, subretinal membrane, help it by the light, and then you can remove pulling one side, pulling the other side, just to avoid to enlarge the retinotomy, or to do like this. Look at this. In this case, I went to a forceps, and I put another forceps that only closes into the tip, but has a hole in the middle, and then you pull the membrane through the hole, and you avoid to enlarge the retinotomy. You will see, I expect the video was now. Okay, look at this. This is a terrible case, I know. Then, in this case, I'm going to go in the subretinal space with a forceps, and then with the other forceps, as you can see, only closes to the tip, but it has you know, it's not totally closed. And then I pull the membrane, I close the forceps around it, and you have a space. And then with the left hand, I'm pulling the membrane, but you don't allow this membrane to break the other retina. And then in this way, you can make a small hole just to avoid large holes. And I think this was to peel membranes. I think there are many more tricks, and I think my colleagues will speak about it. Thank you.
Carlos, please.
Yeah. Yeah, sure. Yeah, I have the microphone. Yeah, tell me.
So, which is your approach when you have a PVR like this, stage 3, let's say, and a hole in the posterior pole?
Yeah, the question is about perfluorocarbon liquid again. If I have a very big hole, I have videos showing this, and I have a very big hole, and I inject perfluorocarbon liquid, and then goes down, then I cut the retina, and I put viscoelastic.
Okay.
You put viscoelastic and you open, this doesn't wait, just open the funnel, and then you put perfluorocarbon liquid. And perfluorocarbon liquid pulls the viscoelastic and open the tunnel. But you know, these cases are very difficult to manage. And the visual prognosis is very poor. I know that. But you can reattach the retina. Pulling first viscoelastic and then perfluorocarbon liquid.
So Elon 5?
Huh? No, normal Hilon I use. Regular Hilon.
Then I do backwards. I start in the periphery without removing, because I get some countertraction from the membranes in the posterior pole, and then leave that for last.
Anterior PVR is much easier in the beginning because it's in your visual axis. If you begin in the posterior PVR, you put more perfluorocarbon liquid, the PVR goes to the periphery. And you have wide field lenses and all of this stuff, and you see. But you don't see the posterior part of the eye on the periphery. In the beginning, it's in the visual axis. It's very easy to cut and remove all the membranes.
And what about the lens? You do lensectomy from...
Believe me.
I agree with you.
Yeah. Lensectomy.
Pars plana lensectomy.
Yeah, I know that many meetings we are talking about phacoemulsification and all this stuff. These are cases that if you don't fix them, you can lose the eye, not the vision, the eye. Then in these cases, try to perform lensectomy, leaving the anterior capsule. Don't remove it, at least during the surgery. If you want at the end, you remove it at the end. But if you don't remove it, I have the total presentation, I have videos showing this. You will have a wonderful, impressive view. But if you remove the capsule, you're done.
Okay, if you don't remove the capsule and then after a couple of weeks it becomes...
No, it's not true. No, I understand what you're saying.
This
is fibrin. This is fibrin. This is
Please say again your question, because I would like them to understand.
Then you answer? Okay.
No, you answer. I want them to understand.
No, the problem with PVR is, and it's totally, I was doing this with diabetics also, and with myopes, in high myopes in the case that you showed this morning. PVR cases, they show opacification because these white lines, this is fibrin. This is fibrin. This is the precursor of PVR. This is the same but in the lens, in the capsule. Then what I do is I leave the anterior capsule and I do a central capsulotomy just to prevent me to see in the postoperative interfere. But forget it, because if you have to put a lens in the second procedure, you have a wonderful place there. In diabetic patients, you don't have this. They don't have so much fibrin. And in myopes, you never have fibrin. You live there and nothing more.
But you're not against phacoemulsification. The message is remove the lens to see better and to complete the anterior vitrectomy.
Completely.
Hold on one second. Is it on the same subject or?
He's younger than me, so.
Let's start with the encircle band and all the PVR cases. So if the PVR is posterior, we are preventing an anterior involvement. If it is already anterior, we are treating the PVR. But you know, if after the peeling you already have the encircle band on, and you need to do retinotomy. So at that time, you prefer still to leave it on, the buckle
Absolutely,
on, or because sometimes you can cross the buckle doing the retinotomy.
Let me tell you why. Yeah. The problem is that when you have PVR, you have an intrinsic shortening of the retina. Then if you put a buckle, for the retina it's very easy to remain in a shortened circle. If you remove it, then the retina has to be to the larger circle. You say, okay, but it will be down. But remember, in the periphery, the circumference is like this. In the equator, it's like this. Then the retina will go down to the equator. Much more difficult to stay there.
The question is mainly related to the tamponade, because if the retinotomy is not in the superior part, sometimes you have the meniscus just in between, in the buckle, and you know the meniscus of the eye. Yeah. So there you can have a detachment.
Yeah, detachment. Yeah. No, I have to tell you, I use, for example, in US they cannot use because it's not accepted, but I use heavy silicone oil, for example.
Yeah. Okay. So in that case you solve the problem because you have a nice. Okay.
Quindi riassumendo, il messaggio del dottor Carlos Mateo è nelle PVR sempre aggiungere un supporto episclerale, cercare di fare peeling negli modi che vi ha fatto vedere, sia delle membrane preretiniche che di quelle sottoretiniche, e riservare la retinotomia solo in seconda istanza. I just have one more question for Carlos, which is specific, and then you'll give your talk. No, you mentioned, and I think it's a great idea, to stain the membrane, because one of the worst things is not to see the membranes. So shouldn't we be afraid of subretinal staining? Or should we be more afraid of not feeling the membrane?
Let me tell you two things. First, I show you wonderful cases, wonderful visualization cases. But many of these cases, Thanasis won't agree with me, some of these cases have pseudophakia. And in some of these cases, you have the capsule opacify. And some of these cases have peripheral, opacification, and you don't see fine. Then a stain, in these cases, will help you to see better the membranes. In some membranes, I agree with you, the dye goes down. But it helps you to localize a small hole.
You don't see great toxicity from the
No, because at the end, you stain, and then you put perfluorocarbon liquid, and you put the dye in the anterior part, and disappears from the peripheral breaks. Then you don't have so stained with the RPA.
Presented a paper that showed that if you cannot find a tear, and you search, you just inject
the dye
behind the retina with a 40 gauge needle, in order to have it coming from the dye in a retinal detachment, and this is how they detect tears. So if you can inject behind the tear, I think you have to think in a big way here. You try to save the eye, not the vision, as she said. I agree with that. And this is minute details of what kind of knives you're going to use. So this is a knife, this is an instrument. So the instrument, you're going to use whatever you have, because you need to save the eye. So if a little goes behind, if a little perfluorocarbon goes behind, of course I agree with Fabio. When I work at the center of the eye, I try to use air to do that. If I can do that, if I can flatten the retina, use air to do that saving for the time, I would prefer, because I have very bad, it's a personal thing against perfluorocarbon behind the retina. Because sometimes when you cannot remove the traction from the tear, whatever tear it is, because you make a tear yourself that is already having a traction around the tear. If you don't remove the traction, the surface tension of the tear, it's always more than the surface tension of the perfluorocarbon and the surface tension of silicone oil.
But we agree.
Succeed at the end, that means that you're going to have some silicone oil behind the eye in a couple of days.
But as far as toxicity and staining, this is a great conclusion. È una conclusione importante. È più importante usare i coloranti e rimuovere le membrane piuttosto che avere timore della potenziale tossicità, perché lavandolo velocemente la tossicità non si rivela, in effetti lo osserviamo. Probably the toxicity effect is when it's more mechanic, I think. When we inject very strongly, we damage mechanically the cells. It's mostly more mechanic than chemical.
People don't understand that the smaller tubing you have for injecting, the power that is hitting the eye, it's incredible. You can open tears, you can tear the whole eye. So it's by 4 increasing the tubing every time you go small tubing. So either you go away from where you want to inject and do it slowly, or use a foot pedal to do that, if I do perfluorocarbon, or in order to inject safely, use a bigger bore.
Yes. We will see some ways to avoid subretinal injection.
Damage.
So, thank you, Carlos. We will hear her vision of treating PVR.
Thank you. I want to thank Barbara for this very kind invitation to one of my favorite countries with the best food. So anyway, a lot of it will be repetitive, but basically, when do we see PVR? We see it with old detachments as primary PVR, but we mostly see it with failed detachment repair. And really, the most important thing when we're fixing a retina is you want to get it fixed one time. You don't want to reoperate these eyes. Eyes that fail the first are the ones that will get PVR, and they're the ones who will do badly. So basically, how to prevent this? In the first surgery, you have to remove all the vitreous. You have to remove all the traction, and you have to find all the breaks by whatever means are possible. And if you have a lot of inferior pathology, I always encircle. If I think that I may need an encircling buckle, I do it, because every time that I have thought about it and not done it, those eyes have not done well. And basically, why do these, let me put this too. Okay, here I'm going to show you 27 gauge. Here this is very mild PVR, so I'm sparing the lens. I do not do lensectomies. I prefer doing phacos in these eyes. And sometimes I put the lens in, sometimes I put it at the end. But basically, you have to remove all the vitreous. And this is why many of these eyes need a buckle. Here in the bottom, you saw all these tiny breaks that are only visible when you try to remove the vitreous. You can't really see them as well in the clinic. And this eye had an encircling element first. And you can do it in any gauge. This was done 27. The important thing is to stabilize the retina, remove all the membranes, and watch for the very tiny breaks, which we can see here. If I already have PVR, a case with PVR, I always put a buckle in. I think PVR needs an encircling element. If the breaks are posterior, I place it more posterior. If there is very significant inferior pathology, I apply support sponges, and I will show you that later. And I think that is very helpful, particularly if you have to do retinectomies in the bottom. And why do you need a buckle? Because in reality, it is practically impossible to remove all of the membranes and all of the tractions in cases of bad PVR. So you will always have foreshortening. And I don't feel that a retinectomy is the answer if you still have membranes that you can't remove, because you will just get crumpling of the retina later on, whether you use gas or whether you use silicone. So I do think a buckle is essential. And I do like Carlos, I like peeling through the perfluorocarbon liquid. I'll just show you a few things. This is actually a case that had a buckle done elsewhere that did not work. I'm performing a vitrectomy. I'm not doing anything with the buckle. It's already there. But here you can see the star folds. And in this case, this is what I like to do. I think Carlos's idea of staining under air is brilliant. It's something that I'm going to start doing, because I think you can see the membranes better here. I'm not doing that. But injecting the perfluorocarbon, what it does is it really opens the star folds so that you can see the point where the membranes are, like here, and then you can remove them. And it helps you visualize that. If I had stained it, it would probably be easier. And then either I aspirate through the breaks. If there's no breaks, I usually do a break, no breaks that are amenable, then I do a small retinotomy superior. Here, as you can see, they're all vid buckles. And the important thing is to really laser all the pathology. Oftentimes, these cases catch you because there's like areas of lattice, like here in the bottom, areas of little breaks that you say you just don't treat, but I treat very aggressively all the pathology that is in the periphery. Here I'm injecting with a needle, which is much better to do with a dual bore. It's what I would do, and I agree with Athanasios that the problem is when we're injecting dye, creating breaks, but that can be avoided with reflux injection and a lot of other things. But here, I'm meticulously treating all of the pathology that is in the periphery. I think those things are key. Retinectomies, I try to avoid them as much as possible. That's why I put buckles. But I do them after removal of all of the membranes. That is really essential. And usually you will need them to be bigger than you think initially. But this is an interesting case. This is a case that already had 3 surgeries, emulsified oil, inferior things. And what I did in this case was I did a scleral buckle revision, putting more support inferiorly where it had all the contraction. And this case, and used gas. And this case did really well, 2080, 1 year post-op. Other cases, this is a case done elsewhere. This is a 38-year-old, 2 surgeries in each eye with oil, count fingers, and massive inferior PVR. You can see the large retinectomy in the eye on the left here. I thought that eye was pretty inoperable. The retinectomy extended inferiorly. And then, so I chose to operate this eye. But the contraction inferiorly was huge. So this is what I did in this case. This case did not have a buckle. This case did not have a buckle. So what I did was I placed a buckle, a 41 band. This takes you, if you do it in the microscope, it takes you 10 minutes. I know nobody likes doing buckles anymore, but it's such a simple procedure that will save so many eyes and will save you so many heartaches. And I've timed it. It takes you exactly 10 minutes to do it. You just put it more posterior than you may think you need, depending on the pathology. If there's more posterior pathology, you may place it more posteriorly. And in this case in particular, what I did after placing the buckle, I went in and I removed all the membranes, as you will see now, and I placed these little sponge elements under the buckle inferiorly to give more height and more support to the inferior PVR. And actually, I went in, did a 25 gauge, removed the oil. It had heavy oil. It had 5,000 oil actually, and it was really, really hard to remove. I had to do it through a 20 gauge cannula, as you can see here. Then I went in, removed the membranes that were posteriorly. All the pathology was inferiorly. It had a lot of laser or diathermy or something. So a lot of those membranes I couldn't remove. I stabilized with perfluorocarbon liquid, which is my preferred method. I think it's essential to make it a lot simpler and to know how much traction you have. In the periphery, there was a lot of pigment. I tried to remove the membranes as much as possible. I cut anteriorly, but the elements that I put actually were great because it allowed for the retina to be supported, and this eye has actually done really well. I have followed him now for, I think it's close to 3 months now, and here he's 20/80, and he's doing well. I don't know when I'm going to take out the oil. I'll think about that. But in essence, it's really, really important to not, I know buckles are not sexy, but I think a lot of eyes need them. I go places and people show me cases that have been operated 8 times, and I go, well, and they're still detached, and I go, well, did you put a buckle? And they look at me like I come from Mars or Jupiter. But but it's really something that can help you. Oil emulsifies, and you get a lot of surface membranes. I don't know why some eyes do this. This is actually a really bad diabetic eye that happened. I usually remove it, from the anterior part, and then, in the back, this eye had massive perisilicone, proliferation, which after removing the oil, I just scraped. And one of the things that is very useful to do that is this little instrument, which is called the scraper. I used to use the Tano, but now I just use this. I like it a lot more. I'm going to advance this for the sake of time. And essentially, this is it. It's the loop, and it helps you scrape those membranes from the surface. And it's actually very useful for membranes or for ILM, and in particular for this massive perisilicone proliferation that this eye did. And this actually happened very quickly, just in like 4 or 5 months. And I always use the same brand of silicone oil, so I'm not completely sure, what was the cost. Let me pause this here. Sorry. Okay, yeah, I think I'm in the last one.
Yes.
Yeah. Well, thank you very much. And
Thank you, Maria.
any questions?
Thanasis, do you want to give your talk on the board?
Thank you.
Let me ask you, Barbara, one question to Maria.
Yes.
When you have this, opacification of the anterior capsule,
This PVR?
PVR cases, do you do something, or you plan to, how to improve visualization? Because visualization in these phakic cases is not good. Then how do you improve this?
I have actually done incisions on it with the cutter.
Uh-huh.
What you do is with the same trocar blade, I go in, do a paracentesis, I put in the cutter, and then I back cut and do like 4 things, and that stretches it back, and that works very well, and the lens continues staying stable.
Yeah, I was doing the same with the
Because
cutter.
I do that in the YAG, in the office. When I have those patients, I just do 4 slits. And
it opens and give you better view.
so you can actually do it before the surgery if you're anticipating.
Yes. I would really love you to ask questions. So.
When you have this kind of emulsification, do you prefer When you have this kind of emulsification, do you perform 2 or 3 fluid air exchange to reduce the emulsification? And do you also use in some cases, particular cases, silicon solvent, FXA, l'FSA account?
PFCL.
Yes. Do you?
What is,
no, not you.
This is PFCL at the end, yes.
Yes.
You used to?
No, I just go into air a couple of times.
This is another subject we're going to have next, to exchange of fluids, and we can talk about it. But usually you're using PFCL when you have a long-standing mixture, because some people used to inject perfluorocarbon and then silicone oil, and they're forgetting the perfluorocarbon inside.
Yes.
Some perfluorocarbon.
Yes.
When perfluorocarbon and silicone oil are mixing inside the eye, then if you try to get it after a year or something like that, usually these people don't come very early, then there's no way to remove them by fluid exchange. Whenever you try to suck them, they stay stuck in the surface of the retina. So the only thing to do is to inject the PFCL, they dilute, and then you take them out. It's a trick. It's just a trick. So I'm talking against Mateo as usually. This is for the last 20 years we do that. I'm against lensectomy. I have people that they were taught by Mateo in Bern School of things, and they came to my clinic, and when I came back to show them doing lensectomies, I had to fix the lensectomies later. So there's a lot of problems doing a lensectomy, and there's no point to leave anything in the eye, because whatever you leave in the eye, from the lens porch part of, it can be a scaffold. So I always remove it. So we have a lady who came from ex-Yugoslavia, and it was the mother of a retina surgeon who was sent away by every surgeon there because his mother had a very inflamed eye and retina detachment. But it was the second eye. So if the second eye, people don't try to do it. They say retina detachment for 6 months. Sorry, I was pressing the wrong button. Doesn't move? Yeah, it does. We do a cataract surgery with, as anybody would do, in this particular 6 months PVR. And you can do a cataract as easy as anybody else can do it. And at the end, we see that there's a peripheral PVR with subretinal strands. And after 6 months, people would have think, put a buckle, do a retinectomy or whatever. No, the thing to do is we try to put another light. We try to use by manual surgery. That's 25 gauge. And that, the most important thing I've seen that everybody now, it used to be a novelty. Now everybody is doing scleral depressor by the surgeon. You don't let your assistant do the scleral depressor. You use a light. This is one of the essential things in PVR surgery. Use a chandelier light.
I can tell.
It's not cost effective, but it helps you do your surgery yourself. And then remove all the traction from the periphery. When the traction from the periphery is gone, then PFCL at the end, and then silicone oil exchange. And this eye was saved at the end and has a minimal vision of 110. So people were not very happy because the other eye had 10-10 vision. This is the way to inject silicone oil when you don't want to have slippage. This is the infusion that can inject silicone oil. It's a Med1 infusion, especially made. You can hit Med1 in the internet, you see it. And you can put silicone oil on one hand and remove the perfluorocarbon on the other hand. You don't have to go through the air exchange steps. And you see that you can flatten the retina without the use of air at the time. So at the end, you can see that it's a foot petal guided infusion like the one you used to do in the old days. So you can use pressures like 60 psi. Look, the incredible thing that they made is you have a 25 gauge. This is presented in 2005 in Sopron in EVRS for the first time. This is the first time presentation of 5,000, 7,000 centistokes in a 25 gauge. Look by 80 psi how stable is the trocar. Because the idea was that the silicone goes around the trocar first and then comes out. So the silicone you're injecting is holding the trocar back. So even if I close while switching it, you see that when I lift my forceps, it starts pulling again, start coming again. So it's an instrument if you want to do an exchange of silicone oil or perfluorocarbon. Direct. I want to go to the other end. So another thing we had is a very young patient who went in coma after an accident with a motorbike. And I'm looking at the young one here, yeah, the angry one. So he was in coma for 6 months. He had retinal detachment when he woke up. So he came to us and said, I want to fix the retinal detachment. I would say it's hopeless because he has a lot of subretinal strands and tears and everything. It was very much a difficult situation. When we saw that there are multiple tears at the periphery also. We don't know how they came back. But the most important thing is that it's a rather flat retina, full of subretinal tissue. You're going to see it here. You did a little bit of cryo here just to detect if we have a tear or not. And you see a flat retina. The center of the eye, the macula, it's okay. You're looking at another one. The people are looking at the right one. And of course, I'm against buckles, but I put a buckle here because there's a lot of subretinal tissue. And if subretinal pulling here, and there's not other way to do it, and now you know that we put buckles with a vitrectomy. So after the buckle, we saw that the eye has a lot of strands and a lot of tissue, but it's you see the V-shaped on this end. I don't know if I have a point. Yes, I have. And this is the most important issue of this video. The vitreous was attached. This is a subretinal strand. This is a subretinal strand. This is a when we showed that a lot of cortical vitreous in the young patient, 6 months of retinal detachment, was attached. And that was the one that is holding the retina flat at the center and detached at the periphery, although they have subretinal strands. So as soon as we remove the vitreous, then the retina became floppy again and moves around and became bullous. But we showed that now we have to do the retinectomy here under air this time because this strand was not leaving the subretinal, the inferior retina to sit under air. So when I do the retinectomy, when I use air and perfluorocarbon, I see that it doesn't go back. It doesn't matter how much membranes it has, it doesn't matter whatever. If it doesn't go back, I need to put it back. So when you see, when I remove the strand from the back of the eye, then the whole retina becomes flat again, and everything is become under air. Mateo used to say PFCL, but I'm using air here because I'm afraid of perfluorocarbon with subretinal strands. So at the end, we're injecting again, and we have a flat eye. And this patient has a little bit of vision now, but the most important thing is, I wanted to point out that in young people, vitreous is not taken for granted that it's detached, and vitreous plays a very important role in retinal detachment. So Kenalog, it's a very important thing in every PVR, in every case you have to do, to check out if there's strand of vitreous, if there's vitreous schisis in retinal detachment. Thank you very much.
Ne approfitto per ringraziare il dottor Mario Romano che oggi ci ha veramente aiutato tanto, purtroppo deve andare via e quindi grazie Mario, alla prossima, grazie. Well, I think that we do agree on some things. We agree that we need a buckle for difficult cases. We need to wait for retinotomies and do it when it's really needed after peeling. And I think we do agree on lensectomy, either fake or removing the lens is helpful. Yeah, it's helpful. So we could talk one day on PVR only, no doubt about that. So I want to show you something to raise some questions. It's, let's say, easy to treat PVR when you can see the membranes, but when you cannot see the membranes. So this is easy. I will not stop on this case of mine because it's similar to what you have shown. So let's move to another one. By the way, I do the oil exchange through PFCL as you do Thanasis. So let's look at this case. My question to you is, when the membranes are not so visible, this is a case that already went through thorough vitrectomy, which are the best technique? So I think you would say now staining with no fear of inducing any toxicity. I haven't used staining in this case because I did have fear. Now I will use them. But the problem was that even with forceps, I could not find with any instruments any real membrane to peel. So the retina was contracted. And so I'm asking you if you have any tips for cases like this. What I did, I prefer to use the Tano scraper. So I said, if I can't peel, I will try to brush. So maybe if they are thin membrane inside the retina, with the scraper, I can break them and lose the traction. So I'm asking you if, do you think that this could be an acceptable technique, or maybe if I had stain, I could have found something?
Membranes are a problem because you can't really, there's not really graspable, they're not sheets. But I think staining may or may not help. But also, I see some of these long-standing PVR cases, the retina is contracted, and no matter, even after you peel everything, it's still
contracted,
massively
yes.
foreshortening. Those are the cases where I think a high buccal, like we used to do way back, could salvage some of these eyes. These are the eyes where I would consider that.
There are different types of collagen for the membranes. So it can be a mature, a new membrane, the membrane that is on the making, so you cannot have a grasp that there are some people in England that they presented also in your retina that they do a PVR case in two surgeries. They do one surgery just enough to sit it down, do half a vitrectomy, and they wait for maturing about 15 days, 1 month, and then they go back and they do the rest of it. Because they said you need a maturing for the PVR. And PVR has a circle. It begins and it has a stop. And they try to go as further to the stop. They don't want to get in the middle of PVR because they have, again, PVR. So in your case, scratching a retina on the surface where it's detached, it's okay with me. The thing that I disagree with you is when you're scratching the retina, when it's on the surface, and when it's pigment epithelium underneath. Because by scratching the retina, you remove the pigment epithelium underneath, you displace the pigment epithelium. And displacing is bad. So that's what Tano used to say. I'm not using anymore the Tano scraper for the attached retina. But for the detached retina and for the surgery I saw you doing today, incredible, congratulations. I was shaking. It was incredible, but not on the surface. On the
surface, on attached.
On a mobile,
non usiamo il Tano sulla retina attaccata. Not on because Tano is a difficult tool. You have to know how to use it.
Yeah.
Carlo, what do you suggest for immature PVR?
Three things about this case you're showing here.
Yes.
The first thing I could do is, again, buckle. I totally agree with you.
You would have done buckle.
Yeah, I know. The second thing is I would do air, and I would stain where these contractions are. Try to avoid breaks.
So you use air as a tool.
Yeah, I stretch the retina. I don't try to attach the retina because you cannot do it.
Yes.
But I stretch the retina, so the folds open just a bit.
Aren't you afraid to break the retina if you stretch it?
If you see that you are, when you are stretching too much, when you have one bubble of air going under the retina, and then you say, you stop it. Because if you stretch more, you can break it. Then if you don't see this, you will be stretched retina, and then you have a stretched retina, you put one bubble over this. You can see here some, you know.
You can see the folds,
yeah, you can see
but
the
you
folds.
can't
Then
see the membranes.
Some dye. The dye will go down to the macro area.
All right.
When you use perfluorocarbon liquid, in this is a difficult case because it's a large break. But you know, try to put more perfluorocarbon liquid. If you want to peel at the perfluorocarbon liquid, you have to be perfluorocarbon over the membrane. Don't be in the edge of the perfluorocarbon liquid bubble, but you don't see it.
And history has repeated itself because the scratcher you use it has been invented by Zivojnovic. And if you go to the door people and say, I need a scratcher, they have a fork-like scratcher for this type of membranes.
Yes,
it's very useful, but for more mature membranes, for this kind of membranes, it's a good idea. I'm going to use it myself because I have some tannins staying there.
Dottoressa Romanelli, dottor Patelli, se avete dei commenti da fare, tips da dare, voi intervenite quando volete. Credo che la PVR immatura sia un problema per tutti i chirurghi.
A quello che ha detto lui con l'aria, se ci pensi bene, prima che ci fosse il perfluorocarbonato
si usava l'aria
per poter appianare, e tanto è vero che allora si doveva per forza togliere il cristallino perché sotto aria col cristallino non si vedeva niente. Quindi quello che ha cambiato molto è l'utilizzo del perfluorocarbonato che ha aiutato, però già allora, prima che ci fosse il perfluoro, mi ricordo che usavo l'aria proprio per distendere la retina e cercare di capire.
La retina e vedere meglio, va bene. I just want to see how this, I mean, it took like 2 hours to stretch and peel and brush. It was very contracted. So my point was some retina are contracting inside, so it's not always easy to remove.
So intraretinal, you can call it. There is a contraction, it's intraretinal.
It's intraretinal.
There is no outside membrane. It can be subretinal also issues that you don't see. You make large retinotomies for many cases, and you have a PVR after a large retinotomy. You have this intraretinal traction that it just doesn't come back, no matter what. It's like coming back again. You stretch it and it comes back again.
Yes. Okay, so down is how it ended, so it's always...
Scusa, Barbara.
Sì.
Però allora, se a me piace questa idea dell'aria, uno potrebbe anche mettere l'aria fino al livello di chiudere le rotture, senza riempire tutto, così hai lo spazio dietro per mettere il corrente.
Sì, dipende, dicevano, da dove hai le membrane. È un mezzo per appiattire, strecciare e mettere più in evidenza le membrane da colorare. Quindi se la PVR è posteriore devi inserirla, devi fare uno scambio completo, se è anteriore...
La metti solo per evitare che il colorante vada dietro la retina?
No, l'aria la metti per strecciare, cioè per stirarla e mettere in evidenza. No, perché dopo...
It helps you to avoid the dye under the retina.
Yeah, but then when you remove the air, it goes under the retina anyway. Quando togli l'aria, Rino, dopo va sotto la retina in ogni caso il colorante, quindi quello non si riesce a evitarlo. So in fact, let's try to move to all the different exchanges that we do, and I would like to hear the different ways in US and outside US. This fear, of course, of using PFCL is justified because I've been taught that the only way of avoiding problems from PFCL is avoiding PFCL. But it's a great tool, so sometimes I think you cannot avoid it. Look at this case. It's the same case on top and the bottom. Retinal detachment with one peripheral break. On top, I'm exchanging fluid with air. So I'm trying to attach in the breaks just with air. On the bottom, I am trying to attach the retina from the bottom with the PFCL. What I want to show you is that in the end, whether you have done straight air or whether you have used PFCL and then air, in the end, it's the same. Because you end up with some subretinal fluid behind the macula.
But that can be avoided.
How?
That can be, you needed to inject more perfluorocarbon liquid all the way up to the edge, and then when you go into air, you have to dry, aspirate for a long time there.
I know.
The same as we do with giant tears.
I know, but I really challenge you to do intraoperative OCT. You always end up with
Always.
some fluid.
Always.
You may
Maybe less.
a little bit,
Always.
yes. But the less you have, the better.
Yeah, but you know,
Whenever you go near the disc to finalize what you're doing, then whatever is left
Will come down.
on the surface, it's coming down again, and it's bubbling. But the point is, that's why so many people, the perfect exchange of air fluid has to be done in macular holes, because people would like to have the
well,
perfect.
that's easy.
So,
It's like
yeah,
going
but
back to
they
posterior
flush it-
retinotomies and
They flush
removing
it 2 or 3 times now. The new ones, they flush the air 2 or 3 times,
Yes,
not
yeah.
once.
Voglio sottolineare bene questo punto, cioè se vogliamo evitare le retinotomie posteriori, come si faceva una volta nei distacchi di retina che hanno le rotture periferiche, il goal è chiudere la rottura. Allora c'è chi la chiude usando solo l'aria, mettendosi davanti alla rottura e aspirando, c'è chi inietta PFCL per fluoro per cercare di spingere da dietro in avanti tutto il liquido sottoretinico e poi dallo scambio aria aspirare dalla rottura. Però poi quando si completa lo scambio per rimuovere il PFCL comunque rimane un pochino di liquido. Lei dice se lo fate con accuratezza più volte non rimarrà. L'unico modo era fare un buchino dietro e aspirare da dietro, però in realtà il nostro epitelio pigmentato è più che in grado di rimuovere il liquido residuo che rimane. But this is very important because when you have a final pocket of subretinal fluid, that's the key to get folds, especially if you had superior retinal detachment, cutting like in half the macula.
you said one thing that is very important. You said, it's the same if you inject perfluorocarbon liquid to the border, to the edge of the break and air after, or air before and perfluorocarbon after. And I totally agree. But if you do first air, the first thing you do is removing all of this viscous fluid under the retina. That air is very potent to do that. Second, you have a wider visual field. Then you see better the periphery. Third, when you have the injection of perfluorocarbon liquid, I explained in Frankfurt Retina meeting last week, you know, you have absolutely less risk to have a perfluorocarbon liquid under the retina because the jet stream under air does not produce perfluorocarbon liquid.
So your message is first air and then PFCL.
In a normal retinal detachment, right?
Yes,
like
peripheral breaks, like this one.
It has the advantage that if you do this, when you perform first perfluorocarbon liquid, you are pushing the fluid to the break in this meridian. But in the other meridian, you are pushing the fluid towards the periphery. And then you are detaching the retina, and you don't see it because we have wide visual field material.
Yes.
Then if you do air and you aspirate only 1 minute there, some of this fluid will remain in the anterior retina and will go down.
Okay.
Then, if you do first, you will avoid this subretinal fluid to accumulate in the anterior retina. And then you will do sandwich.
But you're not doing a full air exchange initially, just
No.
just like a quarter.
Just to the break.
Exactly. A little bit more.
Quindi il messaggio del dottor Matteo è fare l'inverso. Prima fare lo scambio aria, ma non completo, solo per chiudere la rottura e mettere a piatto la retina periferica e poi mettere il perfluoro per spingere da sotto il liquido rimanente e aspirarlo attraverso la stessa rottura. Dice che in questo modo rimane meno liquido alla fine del caso.
Yes, can I say another way on the crisis way?
Don't tell me you don't agree. I would like to.
No, I agree. I agree. But just a crisis way. No perfluorocarbon at all. I saw a lot of people doing it. We started it, and just do the vitrectomy with a chandelier light. Remove everything you can, and then go to the tear. Remove the fluid as much as you can. Exchange simultaneously with air while you're removing fluid. Inject air, and when you finish up injecting air, then turn to gas. And this is going to bring some fluid in the macula every time. And if the pigment epithelium is good, and if you position the patient correctly, you don't have folds. Because even if I have a superior 12 o'clock, I tell them the first 5 hours to stay face down, to leave this fluid, and then position their head. So positioning is very important.
So We now
But
move to
when the
retinal
detachment
folds.
is
Careful,
out
no,
of the
Fabio,
macula,
Fabio.
that's a problem.
Aspetta che passiamo alle pieghe sotto retiniche a questo punto, perché sennò... I just want to show you what I do to avoid subretinal PFCL, because I had subretinal PFCL injection, so now I use a bimanual technique. I just aspirate through the brake with the backflash or with the vitrectomy probe while I inject. So at the same time you remove the subretinal fluid and you keep stable the pressure inside the eye. Quindi lo faccio con una tecnica bimanuale, finché inietto aspiro attraverso il buco con un altro strumento in modo tale da non avere problemi con il perfluoro che vada sotto la retina. Ok, let's cut some of to move to folds. Macular folds. Okay, Carlos.
That's the first, yeah. Okay. Okay, thank you. Folds. We know folds, and it's a very serious but perhaps underreported complication of the retinal detachment surgery. You see, the symptoms: linear scotoma, metamorphopsia, visual field defect. In the literature, it's very variable in the evolution, resolution with visual recovery or permanent damage with visual loss. The established incidence is near 3% of after retinal detachment surgery, and limited macular translocation make these cases to increase. I had, many years ago, I was involved in a large series of macular translocation using limited macular translocation, and I had 3% in high myopia and near 6% in age-related macular degeneration. And which are the risk cases? The first is large buckles. If you put large buckles, it's mentioned in the literature that you have higher risk to have the retina more redundant than to have a fold. But look at these cyst cases. These cyst cases have different cases I have seen in my life. The first case was after buccal and vitrectomy for a giant retinal break. One colleague of mine had this terrible fold. The second was only for a peripheral retinal detachment. You can see a sponge, at 2 o'clock, and the doctor inject a bubble of gas, and then a fold was formed in the macular area. The third is only after plasplanar vitrectomy, no buccal in this case. The case number 4 here down and left is after pneumoretinopexy. And pneumoretinopexy can have also these macular folds. The case number 5 was one of mine, is after limited macular translocation, and the case number 6 is a very rare. Why? Because the inferior retina is over the superior retina, and this is very infrequent. Let me show you where are the high-risk cases. These are the high-risk cases. These are bullous retinal detachment where the posterior border of the retinal detachment is located in the foveal area. In these cases, you are a high risk to have a macular fold. How to prevent these folds? Let me show you. If you are going to perform only scleral surgery, if it is possible, avoid gas injection. And the second, if you have fish mouth, you have to inject, use a steam roller. A steam roller means you have to put the patient toward the brake. If the brake, look at here. The brake is temporal in this case, and then you put the head, the gas is, pushing the nasal side, and then put the patient face down, and then the patient had the macula A touch, and then you can leave. Always pressing the fluid towards the brake. If you do plasplanar vitrectomy, my advice is, first, look at the draws. If you inject perfluorocarbon liquid, as I told you before, you're pushing the fluid up to the anterior retina. Then you accumulate fluid in the anterior retina, and then you put air, but part of this fluid goes down, and then you can accumulate this fluid, promoting a foveal fold. Then I do different. I do the contrary. I perform my core vitrectomy first, and I aspirate. I don't enter in the retina, right? I aspirate the fluid and I put air. And I have the 3 main advantages. First, I have a wider visual field. Second, I attach the anterior retina, avoiding this fluid to accumulate there. Third, fourth, I close the door for the bubbles to enter, because and I won't have any bubble under the retina, and then I put perfluorocarbon liquid and I do sandwich technique. Aspirate, you have a wider visual field, you see perfectly the break. Aspirate, air, perfluorocarbon liquid, aspirate, perfluorocarbon liquid, and then you always end with some fluid. You never, look at this, is a normal, typical retinal detachment. I do my core vitrectomy. I put a buckle, and the first thing I do is to aspirate the fluid, and the fluid that remains there is less viscous. Then I put air. Look at the quality is not so good, but then I put air in the eye, and then I attach the anterior retina, and I can see the vitreous. And it's perfect to do peripheral vitrectomy because the retina doesn't come to you. And then I put perfluorocarbon liquid. I aspirate this, but this was a special cannula that was active aspiration. And with this cannula, I could do the same as she was doing with two hands. I was able to do only one hand because I was injecting and aspirating at the same time. And then you attach the retina and less risk to have a macular hole, a macular fold. Look at this. Imagine that you want to perform vitrectomy in this case. I did only scleral buccal in this case, but imagine that you perform vitrectomy. You perform vitrectomy, and then you have some fluid under the retina, and you begin to inject air in the eye. Then you are pushing the anterior fluid towards the macula. You can see the border of the retinal detachment is in the fovea. Then part of this fluid will be collected under the fovea. Then if you will have this. And then the trick is do it like this, and then when the patient is awake, local anesthesia, put always the patient toward the brakes. Look at this. This was left eye and temporal brakes. Then put it to the left eye because you are pushing with the gas, pushing the fluid towards the brake. Then you won't have any fault. Giant retinal break, again, I told you, try to do it, if I touch it, I'm sorry. Try to do air. Look at this case. Let me try. This is a very old case, it was 20 gauge. Look at this. We are doing our vitrectomy, the retina is very mobile, and then I put air. As you can see here now, you have a wider visual field of view. Then I attach the anterior retina, as you can see here, and I aspirating the subretinal fluid, and then I'm closing the anterior part of the retina, then no fluid will accumulate there, and you are closing the door for any perfluorocarbon liquid. But the next step is to inject perfluorocarbon liquid. Under air, you won't have any bubble due related to jet stream. As you can see here, you are injecting, you can remove the peripheral vitreous, the retina is attached, you won't have more breaks to do this. This is results that published in the literature. And I wanted to ask you, let me show you another case, visual problem. Look at this case. This is the last case. Look at this case. When I read this, I was astonished because this is from Spain. And they show you this patient that is after only 23 gauge vitrectomy for a superior retinal detachment, they have this fold. And they mentioned that progressively the fold disappeared. And I was asking, if you see I have it here. Okay. If you look at this vessel here, it seems that it moves up. Who is moving up the retina? And I doubted, and I said, it's not possible. And I grabbed the two pictures in a Photoshop, and the tilting, I correct the tilting using the inferior vessels, and I calculate the movement using another application. I calculate the movement of this vessel was 480 microns alone, spontaneously. The retina moved up. Then it's true. And my question to you is, in a case of this, would you make surgery? Would you treat this patient or not? Maria? This 0.7 vision. But look at these folds.
I would wait a lot.
I would wait.
I would wait a lot, but I have literature on my side. Because the last paper by Mura and collaborates from Holland show that in 40 cases like that, after almost a year, the outer segment layer has been reestablished completely in a year time.
I didn't mention a paper very old, but they have only 40% had better vision than 2040 in macular fossa, affecting the fovea.
1
1 year.
1 year.
Yeah. Some of them have very poor vision.
For the patient to go to someone else.
Okay, this was very easy. But this patient is from Brussels, and he came to Spain, and he made a consultation in all vitreoretinal surgeons in Spain. And everybody was telling him to be operated. The fovea is here. What's your opinion, Maria? Vision here is 0.4.
I would watch it because
You
the
would watch
fold
it?
is not going through the fovea.
Barbara, watch it. 0.4 vision, the other is 0.6, the other eye.
Watch.
0.42.
0.4 here. Yeah. This
I would watch.
is 3 weeks after the surgery. Fabio,
0.4, I wait, for sure.
Oh, yes, I wait.
wait.
Yes.
Tanasis? Well, you
I operate because I need the money.
Okay. Okay, I was the only one who say, wait, don't touch it. Look at this. This is 6 months. This is the OCT. Look at this. This is horizontal OCT. And this is vertical OCT showing the fold here. And look at this. Oh, no. Oh, me pasa una, no? Oh, no. Wait. Let me show the last one. This is a surgery. Oh, this is the evolution of this patient. This is 4 months later. As you can see here, the fovea remains here, and the fovea fold begins to disappear. Huh?
The retina migrate.
Yeah, migrate. Look at the angioplex. Look at the fovea here, and look at the fovea here. And now the vision is 0.5, he's developing cataract, and he has less metamorphopsia, although he has a black line in the upper visual field. You want to comment about surgery, or you prefer to?
No, I want.
I'm sorry, that's
Sure.
I have a case that I sent to Barbara of a very important macular fold after retinal detachment with a cone finger vision, and after 5 days I decided to do surgery, but I wasn't able to. Here's the case. Look at the case. This is when I do the surgery, but I wasn't able to distend the retina. The retina remained with the fold, and
the only way is to inject.
Yeah, it was a nightmare.
È molto difficile staccare la retina e aprire la. A me è successo di farlo e ho creato un foro maculare.
Yes.
I induced a iatrogenic macular hole by doing this.
So it was a nightmare. So after this surgery, he has a macular fold that resolved slowly in months, and the visual acuity at the end was cone finger. And
Let me tell you what I would do in this case. I would inject. You began perfect in the inferior part, but I would inject 2 bubbles.
this is the second.
What is this?
And then I did the third on the other side. So I detached all the posterior pole. And then when then I did massage, air exchange, PFCL, tried to distend. When I changed with air, again the fold.
Adesso però andiamo un attimo alla questione di come prevenirle le pieghe maculari. Thanasis, you said that you position, let's think about a superior retinal detachment. Very easy, it should be easy. So in the end, how do you position the patient? Face down, you said face down.
Now, the roll technique, which you turn the patient on the table, and hands and knees, and then he sits up. In order to do that is not enough, because it takes a little time to do that. So as soon as you go to bed, he's face down without a pillow, like in macular surgery. And then he stays there like that until the evening, and then slowly goes to 45. So I'm hoping that this way the macula, the pigment epithelium, the fresh detachment is going to absorb, and there's no folds. I'm not going to leave any folds. And that's what I'm doing for the last few years, and I have no problems. In the beginning, because I was thinking of pneumatic retinopexy. The major difference is the vitreous. If you have vitreous inside the eye, you can inject anything and you don't have folds. If you don't have vitreous, then you induce folds with the same system that Mateo is showing. And the only way to avoid them until now is face down. I had cases like that.
No, but let's stick on the superior retinal detachment.
Yeah.
Quindi un distacco superiore che spacca a metà la macula. Tu Federica, come posizioni il paziente alla fine dell'intervento?
Io di solito, cioè per prevenire le pieghe, cerco di far stare il paziente...
Microfono alla dottoressa Romanelli.
No, ce l'ho. Cerco di far stare il paziente un'ora da una parte, un'ora dall'altra, destra e sinistra, proprio per evitare che il liquido possa posizionarsi in un'unica...
Ok, no, mettilo giù quello riguarda che ce l'hai sulla giacca. Che il liquido possa posizionarsi...
Esatto, per cui per evitare cerco di far stare da una parte dall'altra.
Di cambiare la posizione.
Sì, esatto.
Fabio? Face down. I know you're not saying face down because I was taught to put the patient face down, cioè a me è sempre stato detto mette il paziente a faccia in giù, però se c'è uno scambio completo e noi lo mettiamo face down e ha la macula staccata per metà, si formerà la pieghina proprio lì mettendo la faccia in giù. So I was taught to put them face down, the superior retinal detachment, but if you have done a complete fluid air exchange, you will have your little fold of fluid exactly on the fovea. So what I do now, and since it happened to me, now what I do, after filling the eye with air, I put back some fluid, just a few drops, and I counsel the patient to stay face up for a few hours to wait for the absorption of fluid, and then I position the patient according to the rake.
That's what I do too.
Okay.
I was doing it face down for years, but if you really leave them face up, what you're actually doing is you're giving it time to reabsorb all of the residual fluid without having the gas pressing on the retina. So it makes more sense to do that.
I agree with you if you leave fluid.
Yes.
And this is a good technique, but we don't need to completely exchange everything in the eye for an upper tier. You don't need a complete
but that's
field.
only... That's because you use only air, but if you have used PFCL, you have to remove the whole thing. So if you complete the PFCL exchange, then you have to add some drops.
I'm sure you're right.
Allora, anche su questo ci troviamo d'accordo, bellissimo, quindi sul piombaggio, sul cerchiaggio per le PVR, sullo staining delle membrane, sul ritardare i tempi della retinotomia dopo i peeling e sul fatto che per prevenire le pieghe in distacchi di retina maculari superiori sia meglio non fare uno scambio completo e non mettere face down, quindi lasciare un po' di liquido, lasciare a faccia in su e poi posizionare secondo la rottura. I would love to talk with you the whole day about these subjects, but we have to move on. So we have to change the subject now to new ILN peelings because I want all of you. No, sorry. Where are the ILN peelings?